One of the most contentious issues in the Lucy Letby case is a mistake made with a needle aspiration in the case of child O. In this video, we're going to discuss this needle aspiration with the assistance of some experts. So the first time that we heard about this was when Dr. Richard Taylor spoke at a press conference back in December 2024, when he outlined problems in the care and management of child O. These are the words of Dr. Taylor on the screen now. My name is Richard Taylor. I'm a neonatologist from Victoria, British Columbia in Canada, but as you can tell from my accent, I'm originally from the UK. In fact, I trained at Barts, qualifying in 1980. With regard to these reports, I've only read one of them in full, and that is the report on baby O. I should qualify this by saying that I have not seen the medical records myself, but I have read the full report. To summarise the medical evidence, baby O was doing reasonably well. There had been some concerns about abdominal distension, which is possibly related to excess gas going into the gastrointestinal tract. The baby had an apnea. Medical staff responded to this by intubating the baby and placing the baby on a ventilator. The baby was not particularly unwell, but they placed the baby on a ventilator and then put the baby on very high pressure settings. In neonatology, when we ventilate babies, we ventilate by pressure rather than by lung volume. This baby was placed on very high pressure settings, inappropriate given that the baby actually had no lung disease at all. Again, the nurses were concerned that the medical staff had actually left the unit. They then came back. Things didn't look quite right. To summarise what happened, the nurse was again concerned that the abdomen was distended, and one of the doctors responded to this by placing a needle into the abdomen. They directly aspirated the abdomen, and they chose to use a point which, in medical parlance, is called McBurney's point. This is a description of the point used for performing an appendectomy. The baby did not need an appendectomy. This is a newborn, and appendectomy is completely irrelevant. If an aspirate was going to be attempted, it should have been on the left side. Instead, the doctor used McBurney's point, which is on the right side. As I've already said, the baby was on very high pressure settings. This is confirmed by an X-ray of both the abdomen and the chest. The settings were so high that the baby's liver, was pushed down into the pelvis. So when the doctor performed the aspiration of the abdomen, the needle perforated the liver. The baby was still being ventilated with a needle in the liver. The liver was now being lacerated by the needle, and this led to bleeding, with free blood going into the abdomen. The baby went into shock. The shock was actually confirmed by subsequent blood tests, which showed that the baby's hemoglobin had halved, and they were unable to resuscitate the baby, partly because they didn't realise what they had done. And he goes on to talk about his personal point of view, that he'd been able to sleep at night, talking about the surgeon that performed this, which I'm sure you're all aware who it is, and so on and so forth, and about how unjust it is that Lucy's been convicted of murder. Now, I've actually been over all of these points previously. I've been over the McBurney's point issue and several of the other points. I'm going to go over them and the picture of this infant in more depth later in the video. Firstly, I'm just going to show you that we have the document that indicates that the description of Dr. Taylor here is correct. Child O's abdomen was noted to be significantly distended. Dr. Breary inserted an intravenous cannula line to his McBurney's point, the right side of lower abdomen, to try and decompress the abdomen. A small amount of blood was obtained, which was sent for a blood culture. So we're going to reflect on all the mistakes that have been made here and the significance of this needle and aspiration issue. Firstly, I interviewed Michele Worden back in August of last year, August 2025, and we discussed the issues related to child O and the needle aspiration in some depth. Well, it was mostly Michele, if I'm honest. So we're going to hear now what Michele had to say about this procedure and about the mistakes made by child O at that time.
On something else related to that, people have said to me as well, it's difficult to get all the air to go where you want it to go. Do you agree with that?
Yeah. Babies burp, it goes into their tummies, it goes into their stomachs. I've never seen, this splinting of the diaphragm and stuff. It's just nonsense. It's just absolute nonsense. Sorry.
Have a drink. Yeah, that's absolutely great. So, you okay?
Yeah, yeah.
Yeah,
Sorry.
no worries. So I want to just ask you your opinion on Child O, because you mentioned Child O.
Child O, the triplet.
Yeah, and then I want to rewind and talk about the hospital a bit more. But I know that you had, when I spoke to you, you told me a lot about Child O, the failures on the unit, and so forth. So I just wondered if you'd like to speak about that a little bit.
Okay, so from my understanding, Child O was one of the triplets. The triplets were naturally conceived and were all identical, which is very rare. And in fairness to that mum, her placenta fed those triplets equally. They were all on average about 2 kilos in weight, 3 little boys. Yeah, normal pregnancy. It was a high risk pregnancy because they were all identical and because they were born early. Being born in Chester at 32 weeks should not have been a problem. And I'm sure if they'd have been in other level 2 units, they would have also delivered them, even though they had been seen previously at Liverpool Women's Hospital because they'd gone for scans, and there was talk they were going to be delivered in Liverpool Women's Hospital, particularly if they'd have been born before 28 weeks. But they weren't, they were 32 weeks. So they were born in relatively good condition. And if we take Baby O at 1:30 in the morning, the night staff documented that baby's tummy was becoming a little bit distended and you could see loops of bowel. Now, that can indicate problems brewing. So when Lucy came on duty in the morning, she called the registrar to examine this baby. And the registrar said that the tummy was soft. There was some distended loops of bowel they could see, but he wasn't unduly concerned. This baby, I think, was 3 days old at this point, and had not had its bowels open, which is a red flag. So Lucy continued to feed it down its nasogastric tube, and I think the feed was given at 12:30. At 1:30, it vomited, this little boy vomited, and had quite a profound desaturation and bradycardia. That's a slowing of the heart rate and a dropping of the oxygen. Now, this is where it starts to go horribly wrong. At that point, the baby only had a peripheral cannula in, so just a normal cannula with a drip. And the registrar was called and about 10 to 2 and intubated this baby, and this baby was moved from high dependency back into intensive care. Now, the first failing was that registrar then just left. If you have a baby in intensive care, you need more than one peripheral cannula in situ. So if I'd have been there, I would have cited a UVC, possibly a UAC, or put a central line in, a long line, and an IA line. So an IA line is an intra-arterial line or an umbilical arterial catheter or an umbilical venous catheter or a long line stroke central line, because those go into much bigger blood vessels. And if a baby continues to desaturate and to bradycardia, you might need to give some very potent drugs. And you should never give those drugs via a peripheral cannula. But that doctor just left that baby and walked out. So this baby is now in intensive care. And it's about 2:00 in the afternoon. I think about 3:30, the baby had a further profound desaturation and bradycardia. And the registrar was crash called, and he happened to be walking along with the consultant who was on call that day, who is one of the anonymized consultants. So they came to the neonatal unit. They extubated the baby and re-intubated the baby because they thought there was maybe a problem with the endotracheal tube. At that point, they started to put another peripheral cannula in, but the baby continued to have desaturations and bradycardias. They called Steve Breary because Steve Breary has an interest in cardiology, and they were querying a possible cardiac abnormality. So Steve Breary came and performed what's called an echogram, which is via an ultrasound scanner. And there's an ultrasound scanner on the neonatal unit all the time. And he scanned the baby and said that the heart was fine. The resuscitation now is becoming more frantic as time goes on. And they've still only got a peripheral cannula in, which they gave adrenaline through. I believe that Lucy documented in the notes that the fingers and the hand were going white. Well, that's because adrenaline is a vasoconstrictor, and you should never put it through a peripheral cannula. But they didn't have any other lines in. So they're getting into deep trouble here. The abdomen is distended. So Steve Breary decided that he should try and deflate the abdomen by releasing the air that he thought was in the abdomen. This is where the second mistakes happen. So first of all, he documented that he used McBurney's point. McBurney's point is not relevant in neonates at all. It is a position that is used to diagnose appendicitis. And this baby categorically did not have an appendicitis. In fact, I've never seen a neonate with an appendicitis, so I don't know why he decided to use McBurney's point. He'd had an ultrasound scan by him because we know he'd performed an echocardiogram, but he didn't use the ultrasound scanner to check the position of where he was inserting the cannula. So that was another mistake. And he inserted the cannula on the right-hand side of the abdomen, which is where the liver is. I was taught if you are aiming to cannulate an abdomen in order to deflate it, you always use the left-hand side. So he had a scanner. I don't know why he didn't use it. I don't understand why, if he was going to go in blind, he didn't use the left-hand side. I don't understand why he was saying McBurney's point. This baby had been overventilated, so its lungs were hyperinflated. So when they'd first put the baby on the ventilator, they'd use very high pressures. But this baby didn't have lung disease. So I don't understand why the pressures that they used were so high. But what that happened was the lungs got bigger and bigger, like blowing up a balloon. And as they got bigger, they were pushing the abdominal organs further down. So even though he inserted the cannula at the level of the umbilicus or just below, the liver had been pushed down. So he hit the liver. Now, there is talk that this baby had a subcapsular hematoma of the liver. I don't know how the baby got a subcapsular hematoma of the liver. There is talk that it was maybe due to the cesarean section. There is talk that some premature babies can just develop subcapsular hematomas. I have no idea why this baby had a subcapsular hematoma. But a subcapsular hematoma, if you imagine the liver, it has a very thick covering on it, which acts like a pressure bandage. So the hematoma is bleeding into like a bubble, the capsule, but it's been held back because of this thick fibrous tissue that encases the liver. Once that was breached by inserting a cannula, then the baby could just bleed out. Now we know that when the baby was first ventilated at 1:30-ish, 1:50, a blood gas was performed. And on that blood gas, it showed the hemoglobin, and the hemoglobin at that point was 197. When they did a further blood gas at 5:30, in the middle of this full resuscitation by now, the hemoglobin had dropped to 86. Now, even if Steve Breary didn't recognize the difference between the blood gas at 2:00 because he hadn't seen it, he documented a hemoglobin of 86, and he would know that is not what that baby's hemoglobin should be. So a further mistake was nobody recognized that hemoglobin was low and thought to themselves, let's give this baby some emergency blood. Because this baby, we now know, was bleeding out. So it was going into hypovolemic shock, and nobody thought to give it any blood transfusion. In the meantime, Dr. Gibbs had arrived at approximately 4:20 because he was the consultant who was going to be on call that night. So he'd come to the unit to see what was happening and walked into the full resuscitation. And because they still hadn't got any central lines in, he cited an intraosseous infusion, which basically means you put it into the femur, and it gives you direct access to a big network of arteries and so on to get fluids into this baby. So there was numerous things wrong with this resuscitation as it went along. And tragically, I think about 5:45, 6:50, they withdrew treatment. They said the baby had passed away. Just awful, just awful. I think if they'd have definitely recognized that that hemoglobin was low, they could have given that baby some blood, some FFP, whatever. But it was just a catalogue of mistakes. And I think the mistake really first started earlier on in the day when they failed to recognize that this baby was slowly deteriorating with a distended abdomen, having a profound bradycardia and desaturation, which is what babies do when it's there. That babies don't have cardiac arrests. Babies have profound desaturations and bradycardias, and that's their way of saying, I'm not well. I am really not feeling 100%, and I'm not well. And babies, some babies, especially really prem babies, will have desaturations all the time. You know, they just go up and down, and quite often they'll recover spontaneously. But as the neonatal nurse, you should recognize if a baby's having a desaturation and a bradycardia, that is that baby's way of saying, I'm just not well, I'm exhausted, please help me. And a good neonatal nurse would pick up on that, and a good team. They failed on many levels there. They didn't recognize this baby was deteriorating. The doctor, when he first moved the baby back into intensive care, just left. I mean, it's just ridiculous. He didn't put any lines in. That baby had one peripheral cannula in intensive care. You talk to any intensive care nurse, whether it's pediatric, neonatal, or adult, and they will all tell you that patients in intensive care have numerous lines in, not just one peripheral one. So it's just a tragedy, and I feel so sorry for those parents of those triplets. It's just awful.
So I have a couple of follow-up questions. So you touched on both of the answers already, but I just want to reiterate this really. So when I looked at this case, I have a fraction of the understanding and knowledge that you have. But I just couldn't understand why you wouldn't use imaging for the procedure. Like, can you think of any conceivable reason why that wasn't done?
I don't know. I mean, maybe he panicked. Maybe, yeah, panic, or I don't, I don't, I don't want to particularly call out Steve Breary because, in medicine, things go wrong. Accidents happen, people make mistakes. I don't believe anybody intentionally makes a mistake that will end up in the demise of a patient. But it happens. That's just a fact of life. In the case of this baby, though, there was a catalogue of mistakes that were failed to be realised. The fact that the night staff were reporting that this baby had distended abdomen, had loopy, you could see the loops of bowel through the abdomen, that the baby had a desaturation and a bradycardia at lunchtime, had a vomit. And then it just became the knock-on effect. The registrar intubated the baby and then left it.
Hmm.
I mean, I don't know what to say, because I would never have left a baby like that. I would have stayed and put in lines, because in your head that if a baby requires ventilation, the chances are it could deteriorate further, and therefore you're going to have to give it some very powerful drugs. And those drugs should not be given through a peripheral cannula. They should be given through a central line or a long line or a UVC, whatever. Excuse me. And then, yeah, it was just one mistake after another. Steve Breary came, he had an ultrasound scanner. I don't know why he decided to use the right side and didn't go in the left side. They didn't recognize the drop in the hemoglobin. You've got to remember, this baby, if he's 2 kilos, he has got a circulating blood volume of approximately 180 mils. That's about a cup of tea. If it halves so that you lose 80 mils, that's a small amount of fluid, and that's going to cause hypovolemic shock. So they could have very easily given this baby blood. I don't know if it would have changed the outcome, but it certainly wouldn't have done it any harm, and it might well have helped a great deal.
Yeah. So I agree with what you said about mistakes happening, and I'm sure everyone did try their best on the internet. And when I talk about this, I do try to firstly be fair-minded, and secondly also acknowledge that this is a very challenging occupation and profession, and they're dealing with life and death circumstances. They're human; they have emotions, as you say, and also I'm always conscious of the fact that I don't work in healthcare. I wouldn't, because I understand the pressures that are involved, and I don't have any qualifications to do so. With that being said, if you could summarize, like, how bad were the failings in this case?
I think there was numerous missed opportunities. The biggest one was that the doctor left at lunchtime and didn't put any further lines in, because that would have saved a lot of trauma later on. The other thing you've got to remember is, though, that Steve Breary and this consultant, who was anonymized but is in the gang of 4, as they say, that pointed the finger at Lucy, did this become a self-fulfilling prophecy that they already, by the time this baby was sick, had it in their heads that Lucy was doing something? They didn't know what Lucy was doing, but they definitely thought Lucy was the reason that these babies were becoming sick, were collapsing, and were dying. So they get crash called to the unit, and the nurse there is Lucy. So did they just completely panic, thinking, Lucy's here, what's gone on? Rather than focusing and using all their clinical skills on the baby, they were going down a completely different direction in their heads while they're trying to resuscitate this baby. Because they definitely, by this time, thought she was doing something. And did that cause further problems during this resus? Because they just went into panic mode.
Another guest who we've had on the channel who has discussed the needle laceration issue and who is particularly relevant is Stephanie Davies. So Stephanie was working with Cheshire Police at that time and was asked to review the details of these infants. So I actually interviewed Stephanie just a few weeks after Michele. It was in September 2025, and at the time we discussed what had occurred with the review and whether there had been any mention of this needle aspiration in any of the documents submitted at that time.
So, firstly, I just want to be clear that we have the document from the thermal inquiry where it describes this aspiration, and it describes blood being drawn as a result of this aspiration. Okay, shut up. Just rain. Fine. Speak out. Quiet. Kate. Right. Do you need to go out? Go on. Out.
Fair enough.
Right, sorry about the interruption, everyone.
No.
He gets excited by rain, so there's not even thunder. Oh, maybe there is. Maybe there is a little bit.
Yeah, they can hear a lot better than us.
She's gonna have to stay out there for a bit.
Yeah, the procedure, I think it was a few months after the post-mortem when apparently the procedure was then made known. Too late. You know, we have the post-mortem, I think it was done in June of 2016, and the pathologist produced his report. It would have been at least a couple of months later. So that information, I think, came out in November time, if I recall correctly. But I wasn't aware of it, and I don't think the pathologist was either. So why not give the information at the beginning?
Yeah, so there has been a little bit of controversy about that.
Yeah.
But both the preview report we've seen from the expert panel and the comments that were made are consistent with this document. And also, it was suggested that when the aspiration took place, they used the wrong side of the abdomen. That's correct. I mean, I've shown that in the previous video, but I'm going to do a full video on Child O soon. We know they aspirated blood. So all those details are actually confirmed. There is no controversy about this at all. I'm just going to let my dog back in. She's crying.
Oh.
Kate, when you come. Yes, you can come back now. Right, you're going to lie down there. You're going to be quiet. Good girl. So actually, there is no controversy about Child O at all. Really, the controversy is why wasn't this reported to the coroner when blood had been aspirated?
Yeah.
It can be very significant, as you say. So could you? I mean, obviously, there's a degree of speculation here, but could you think of any good reason why that wouldn't be reported?
An innocent reason would be it was not thought to have contributed at all. So, and it could be that the doctors that were involved with Baby O, they thought it's not a factor, it's not a significant factor, it's not relevant whatsoever. And that could be, it could be that they're almost blind to their own weaknesses. You know, for example, the aspiration of blood, they may not have realised, oh, that means the procedure could have gone wrong. They may not have realised that or recognised it. So there could be an innocent explanation, but a non-innocent explanation would be, well, if we inform the coroner of this will turn into an inquest case. That'll be closer scrutiny to our practices in the unit. And And we don't want that. We have to have a post-mortem because we don't know the cause of death, but we're expecting a natural cause. That's a more sinister reason. And I don't know which it is. I don't know which it is.
Yeah.
It could be an innocent explanation. It could be a sinister one.
Yeah.
And it's open to debate. It's open to speculation. We'd have to ask those doctors themselves, and whether they're truthful in their accounts is another matter. We don't know.
Yeah, that's fine. So I want to ask you about your actual. See, at some stage you've conducted a 3-hour review for Cheshire Police of the Lucy Letby case. So could you tell me a bit more about that?
Yeah, sure. So from what I can gather, a letter was sent from the Countess of Chester to Cheshire Police. It was dated the 2nd of May 2017. And I am certain it was a Thursday that I was asked to go to police headquarters. So I think that would have been the 4th of May on the Thursday. It was in the afternoon. And I didn't know what this meeting was about. I was just told I was required to attend a Gold Group meeting. So Gold Group meeting, very high level police meeting.
Okay.
And it's basically to discuss strategy about what direction they're going to go in. Very high level. And I hadn't been to a Gold Group meeting before, so I thought this sounds really important. I'd only just been promoted to senior coroner's officer, so I was already quite, I'd taken over from Christine Hurst, who was my predecessor. So I went over to police headquarters. I'm certain it was in the afternoon on a Thursday, and there was discussion about this letter that had been received from the Countess of Chester asking the police to investigate. And the consensus around the table, there are a lot of senior police officers around the table. They were all saying there's nothing to investigate. There's no crime, there's no active crime scene anymore, there's too much of a time delay, there's no evidence of criminality. I can't remember the exact reasons why they weren't going to investigate, but it was along those lines. And the Assistant Chief Constable, Darren Martland, then turned to me and said, before we confirm with the hospital that we're not investigating, please can you confirm that these causes of death for the babies are explained? So at the time, it seemed like a straightforward task. And they said, we need you to report to us tomorrow morning. So, and I thought, this is Thursday afternoon. Generally, our working day ended at 4. I didn't get back to the office until after 4. I think it was 4:15, if I remember rightly. All my team had gone home. They all finished at 4. So they're out of the door by 2 minutes past 4. So I came back to the office. It was all in darkness because they turned all the lights off. And I thought, okay, well, generally the town hall building would shut at 6:30, but I could request to stay till 7. So I asked, can I stay a bit later till 7? So that gave me just under 3 hours to do a review. I had no idea how many deaths there had been in the time period. So I was looking at, I think it's from the beginning of June 2015 to the end of June 2016, so a 13-month period. And I'm trained in some software that helps you to extrapolate information from our coroner's database. So I selected some fields. So the search parameters, all children under the age of 1, so age 0 on our database, because we go by years, who died at the Countess of Chester Hospital, and during that time period, and I found there were 13. So, which is higher than you would normally get. Normally you get maybe 2 or 3 a year, but 13 over a 13-month period was quite significant. I was able to then, I just populated all the information into a spreadsheet, and I added a couple of columns so that I could then look into the paper records that we had and also what we had in our database. The main thing I was interested in were post-mortem reports, because that is a very detailed medical examination. Some of the cases, it was literally a discussion with the coroner's officer. So a doctor saying, I can issue a death certificate. These are circumstances. And all deaths of children had to be reported to our coroner at that time. So Mr. Reinberg, he was a senior coroner over 2015, 2016. So all deaths under the age of 18 had to be reported, even if the cause of death was known and natural. generally, as I was going through all the paperwork, I was looking especially if the parents had raised any concerns about the care. I was looking at the actual cause of deaths themselves, which were really on the surface all natural. They all appear to be natural causes. And it wasn't like the same cause of death each time. There were variations, because pediatric pathologists are incredibly detailed in their post-mortem examinations. It's not the same as general standard coroner's post-mortems on adults. Those post-mortem reports would be maybe 2 or 3 pages long. Pediatric post-mortem reports are 15, 20 pages long. They're incredibly detailed, so many different tests done. So I was looking through them, and I thought, I'm going to have to go back to the police and say that it's natural causes. There's no evidence here of anything untoward. And it was only when I saw a couple of post-mortem reports, and I think it might be for babies O and P, and certain one of them was baby O, because there was discussion about blood around the liver, and the pathologist was explaining how this is a sequence of events, but I don't know what started it, so I can only give prematurity. And that's when I thought there are gaps here. I was really short on time, but it was a reasonably straightforward task. The police had already pretty much decided we don't want to investigate. There's nothing to see here. So I thought, well, I just need to answer their question. And I was expecting at first to say it's all natural. I don't think there's anywhere we can go with this. But it was those comments in those, I think it was 2 post-mortem reports, that really made me think, no, there are gaps here. There's something unexplained here. And so I finished off the spreadsheet. I didn't have time to write up my formal conclusion. I ran out of time. I didn't have time to print off the spreadsheet either. So the following morning, I went straight to police headquarters, and then I delivered my conclusion to them. And I said, in my opinion, the causes of death for the babies are not sufficiently explained. There are gaps. There are missing jigsaw pieces. And if the hospital are now presenting new information or new evidence, then it may well be that those causes of death need to be modified. Now, I'd expect there would have been a loss of consultation with those original pathologists. Now, I don't know if that happened. I don't know, because I had nothing to do with Operation Hummingbird after I did my review. But I would expect, at a minimum, those original pathologists would have, a long conversation anyway, about those causes of death, and maybe going through the medical notes again, maybe getting an independent expert, a relevant independent expert, ideally chosen by the coroner and not the police. I think that may well have prevented this whole thing from happening.
So finally, if we look back at the picture of child O, this was a triplet born at 33 weeks gestation in labour caesarean section. So this is clearly a vulnerable infant immediately. Weighed 2 kilograms, had mild respiratory distress, requiring CPAP and oxygen. Triplets were extracted at caesarean section very quickly, a minute apart. And then there's a lot of details about what's been already discussed regarding the desaturation and kind of varying state of this infant. The purpuric discoloration seen transiently has been used as indication of air embolism, utterly ridiculous. It's nothing to do with the clinical signs of this infant. Complete joke that it's in court. And you see the mention of the needle aspiration and problems with blood gases circulation, and eventually, sadly, the infant passes away, with post-mortem showing a ruptured subcapsular hematoma of the liver. So here they just mention the allegations. This involves that child O somehow received blunt trauma, and that there was injection of air into the circulation of this infant. Completely preposterous. And I'll read the full explanation here. Child O collapsed because the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity sufficient to cause a near halving of the hemoglobin level. Subcapsular liver hematoma is the result of traction or shear forces applied to the thin, fragile liver capsule through the hepatic ligaments. In baby 15, this was likely the result of the extremely rapid delivery, which is a well-recognised cause of birth injury. Bleeding into a subcapsular hematoma is characteristically initially slow because it is contained by the pressure of the enveloping liver capsule. In these early stages, the clinical signs are insidious and difficult to recognise. Of course, that's exactly what they failed to do. They failed to recognise the circumstance of this infant. High pressure ventilation decreased venous return to the heart and contributed to liver congestion. The slow deterioration is then characteristically followed by acute collapse, and when the capsule ruptures, releasing free blood into the peritoneal cavity. The significance of the rising heart rate and falling pH before the terminal collapse were not recognised. The blind abdominal insertion of a needle during resuscitation may have penetrated the right lobe of the liver, causing further injury, noted by the pathologist as parenchymal hematoma and laceration. Blunt direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in a liver protected by the lower chest wall. The gaseous distension of the intestinal tract was likely due to air swallowing and insufflation during non-invasive respiratory support. The suggestion of injection of air into the circulation is conjecture, which I think is a generous description, frankly. Child O died from a subcapsular liver hematoma caused by a traumatic delivery resulting in hemorrhage into the peritoneal cavity and profound shock. This was not recognised ante-mortem. So obviously prior to death, that means. So what we see with Child O is something that we see across all of the infants in the Lucy Letby case, which is that it's not just one problem, and it's not just one issue. First of all, there's a fundamental misdiagnosis. There's the failure to recognise a subcapsular hematoma. The signs of a subcapsular hematoma were missed, and so they didn't know what they were dealing with. I was talking to my friend this morning who was an ITU nurse, and she said they wouldn't have recognised a double-decker bus if it was stood right in front of them. I can't really comment on that because I'm not a medical professional, but I thought I'd recount that to you. So they miss a subcapsular hematoma. So, I mean, this was described to me as a fundamental failure of diagnosis. So, as I've mentioned in previous videos, if you misdiagnose, you've got problems immediately. Now, if it's something relatively trivial, then obviously it doesn't result in death. But if it's something serious in a vulnerable infant you misdiagnose, that infant's in big trouble. Then the second thing is medical error. So we see multiple medical errors across these cases in procedures. Obviously, the biggest one that they do badly typically is intubation, but here there's a needle laceration that's caused by a blind and incorrectly conducted procedure. And then thirdly, there are them compounding already the massive problems and mistakes in treatment. So the infant's ventilated incorrectly and they shouldn't even have been aspirating the infant in the first place. So across all of these cases, so many of the infants in the Lucy Letby case, it's not just one mistake, it's multiple errors that compound each other, and that's why the infants collapse. Whereas Dr. Evans has come in and said, oh, look, it's just air. It's air all the way through. And then when there's other things he has to explain, he'll just essentially concoct something about, oh, Lucy used an indeterminate tool. Lucy punched the infant. Lucy did this. Lucy did that. It's not medical diagnosis. It's complete rubbish, essentially. So it is now just 1 month until my book on the Lucy Letby case is released. In this book, there is a lot more detail about Child O, including additional expert opinion and information. It's obviously a very important case in the trial because it was one of only 3 that had a unanimous verdict. Many people believe that this was a strong case, when in actual fact it's an extremely weak case, and the allegations regarding the prosecution or that were made by the prosecution are simply total rubbish. So I hope you found this to be an illustrative and informative video. I'm obviously quite busy at the moment, as you know, but I managed to get this one recorded. I've got something planned for the next few days, so I'll hopefully be able to keep recording. I just have not had time to go through the comments as I usually do, but please do keep leaving them because it really helps. And at some point in the foreseeable future, next week or so, when I've finished recording the audiobook and I've got more time, then things will return to normal. I'll have a bit more time to think about YouTube and I can take it a little bit easier. But I really appreciate all the support, and I look forward to catching up with you all soon.